Afternoon, everybody. Warm welcome to our AWIMS special He for She launch. My name is Dr. Vidya Prakash. I am founder and director of AWIMS, SIU Medicine's Alliance for Women in Medicine and Science. Before we get started with our panel discussion, I would like to tell you a little bit about our He for She initiative. We have the great leader of our initiative, Dr. Robert Robinson, who is here with us. And he was able to get together a group of very committed members of our SIU community to launch this very special initiative. And our mission statement for He for She is to recruit men and people of all genders to work in solidarity with women in medicine and science to eliminate the gender equity gap. And our vision is an obsolete gender equity gap. I have the great privilege of introducing a set of tremendous leaders throughout Springfield, Illinois, and throughout our SIU system. I will start with Dr. Sheila Caldwell, who is our Vice President for Anti-Racism, Diversity, Equity, and Inclusion, and the Chief Diversity Officer for the entire Southern Illinois University system. Next, we have Dr. Raj Govindaya, who is Senior Vice President and Chief Medical Officer at Memorial Health System. We also have Dr. Jerry Cruz, who is our Dean and Provost of SIU School of Medicine and CEO of SIU Medicine. And we also have Dr. Gurpreet Mander, Chief Medical Officer of HSHS St. John's Hospital, and Dr. Wesley Mcneese, our SIU Systems Executive Director for Diversity Initiatives. Warm welcome to each of you. We are thrilled to have such an amazing group of visionary leaders to talk about this very important topic. I'd also like to introduce our moderator, Dr. Christine Todd, who is chair of the Department of Medical Humanities and co-chair of our AWIMS Wellness Initiative. And I'm really looking forward to this discussion, Dr. Todd. I will be moderating the chat as Dr. Todd conducts her panel discussion. So please feel free to use the chat and we will get to as many questions as possible. And I would like to remind everybody that this session will be recorded. So without further ado, Dr. Todd.
Hello and good afternoon to everyone. I am going to start by asking our panelists to share just a little personal experience that highlighted the gender equity gap from them. We are all people who, of course, care a lot about all the different people we work with and care from, but often there's something that we're very proximate to that happens in our family or in our close circle that is a wake-up call on things like this. So I would love to hear a little bit about that. And I'm going to start with Dr. Caldwell. Can you tell us a little story about something like that?
Yes, I actually have a timely story. I have been with the SIU system for approximately 7 months now. And one of the things we know that when you move to a new area, you basically have to start over in terms of seeking new healthcare providers. So in some ways, I would say much to my dismay, I have been unable, I'm going to actually speak about intersectionality, me being an African-American female, and there are some doctors that I prefer to be African-American. Like I specifically would like to seek out an African-American gynecologist. I have 2 daughters. I have actually had them experience Black pediatricians in the past, and they have been able to intervene and catch certain things that when they went to other doctors that was not as obvious based on their lived and personal experiences. So just me trying to secure maybe an African-American gynecologist, pediatrician, even a dentist, I have not been able to do that to the point where now I'm going to actually call the insurance providers and see if they can help me secure that. And for some people who might be listening, we know that doctors are obviously adequate, they're experts, they're all trained in the medical field. So people may say, well, why is it important to you to have a Black female doctor? And I would say just really quickly, I'm just going to highlight a few data points. One of the reasons why I would like a female doctor for some of the specific, not in all cases, but in some cases that For example, in 2016, not that long ago, the National Academies of Science reported that half of medical students and residents actually believe that Black people have thicker skin, a less sensitive nerve endings than white people. Black patients report spending less time with white providers, reduced patient care, and reduced shared decision making. Black women have the highest maternity mortality rates, which was why it was important to me to have African American doctors deliver my babies. The Black community is more likely to experience mental health disorders and is less likely to receive treatment for those disorders than other racial groups. And overall, they just have worse health outcomes such as hypertension, health disease, diabetes, and lung disease. So when I think about all of those collective issues, they really can have meaningful and significant impacts on your health outcomes. And if I can close some of those gaps by securing healthcare providers who not just have the professional and medical expertise, but some of the lived experiences, that's important to me. And again, I have not been able to do that in Springfield. And so one of the ways I've tried to mitigate that is by specifically talking to doctors, and they've given me referrals. I even go to church and then they'll also give referrals. But if I was to be honest, if I was necessarily wanting to only secure white providers, I probably wouldn't even have to rely on my informal networks. I could just do a Google search. If I do a Google search now, I'm not able to actually find those healthcare providers. It's not, and I've done it several times. I've done surveys, I've called people, to get on a callback list, and I have had very little success with being able to secure a doctor. And usually within a year, you would like to try to do that. And like I said, it's been 7 months, and I've been diligent. So, and the last thing I want to say is that Black women represent less than 3% of all U.S. doctors in healthcare. So when I think about gender disparities and gender inequities, that's one thing that's blaring to me. And again, it's impacted me in a personal way as I try to secure healthcare for myself and my family.
Dr. Caldwell, you highlight really well the whole reason why we need to talk about this subject, which is, in the end, people need to be able to find doctors who understand their cultural context, who they feel comfortable with, and who understand the challenges that they face. And we're not there yet. That is for sure. All right. So Dr. Cruz, tell us a little bit about your personal experience with this issue.
Okay, so my personal experience is one of the early ones. When I started medical school in 1975, our medical school class had by far the largest number of women ever at my medical school, by far. It was a big, and it was apparent from the first day in lectures, small group, and rounds that the women were not part of the club. They were always on the periphery. The language spoken was very different, a lot of sarcasm, and it was difficult, for our class. It was certainly difficult for the women in our class. Recently I gave a couple talks about delivering difficult messages. Radical candor, and the two axes. The x-axis is challenging directly, and the y-axis is caring personally. And if you're down in that lower right quadrant, you don't care personally, and you challenge directly. It's called obnoxious aggression, and that's pretty much where it was. And those people who do that have to have targets. At that time, the women were the minority group, for sure. There were very few African American students, faculty members, or anything else at that time in my experience. But anyway, it was really apparent, and I think it shaped my entire attitude, the way I approach things from then on.
Yeah, absolutely. It is, I think sometimes our trainees and our medical students have the best observations about this because they haven't assimilated into the way things are yet. And when they arrive, they're like, wow, so this is how it is. And we really need to hear those perspectives and remember what it was like when we were there too. Absolutely. Dr. Mcneese, I know you have some stories to share.
My story is also old. It was back in 1999, March of 1999, when I was finishing the middle shift in an emergency department, Riverside Medical Center in Kankakee, Illinois. I was going off duty and a new doctor had come on duty. The new doctor for the night was a woman. And I started getting phone calls, a couple from the administration and one from the local paramedics. There had been a train derailment, an Amtrak train had derailed in Bourbonnais, Illinois. And we knew that there was going to be a big problem, and they wanted to know who was working. Are you still there, Wes? Are you going to be there when we have to activate the recall? All those kinds of things. And I pointed out to them who had come on duty and who was going to be in charge. I was really supposed to be going home. And they didn't like the fact that it was a woman. And they were trying to convince me to take charge of the recall and take charge of the emergency department, even though she had been there for an hour already and was the one who was to be in charge. And what I sensed is that there was a sense that there was sort of an incapability or an unsuitability of this woman to manage the ER and to manage the train derailment. And I've seen that attitude. I saw it then, and I've seen it carried forward even today. Well, I stayed, of course, but I stayed as her second, as she managed the tragedy and did an excellent job doing so. And I believe that the gender inequity gap often has at its roots this sense of incompetence or unsuitability or incapability, and that's totally wrong. I learned it then. We need to learn that now and continue to keep it in our minds as we move forward with our profession.
Thank you, Dr. Mcneese. Dr. Mander, can you tell us a little bit about your personal experience with gender inequity?
Yeah, thank you. Thank you for having me here today. I think I'm here to share my experiences and HSH's experiences, but also as much to learn from all of you. And this is a personal journey for all of us. You know, I grew up in India and then migrated here a long time ago. We always knew gender equity was pervasive, but I was a little surprised to see how pervasive it was in the United States, which is considered the most advanced and developed nation in the world. But having said that, I'll move from circa 1975, Dr. Cruz, to 2021, and just share an incident from one of our senior medical staff meetings about a year ago, where we were having a very difficult discussion about some medical staff issues. And two of our senior faculty members, both professors, were participating. And on a consistent basis, the male faculty member continued to interject and talk over his female colleague until the point that he was called out to do that. So we made a lot of strides, but unfortunately, these issues still exist, and I'm glad we're talking about those.
Thank you. Dr. Govindaya, I know he is dealing with a couple of situations right now, so I'll hold off calling on him until he's done. There's always like 14,000 things for someone like him to be doing. So I would love to hear a little bit about the current state of gender equity in your respective organizations, and also sort of where you're hoping to move to. So Dr. Cruz, do you want to talk about that just a little bit? And Dr. Mander, I see your hand.
Yeah, after Dr. Cruz.
Oh, Gurpreet, do you want to go first?
No, Jay, up to you. Mm-hmm.
Okay. Yeah, I'll say a few words about this. I'll just say that over the past 8 to 9 years, we've been very intentional about at the SIU School of Medicine. There are some things that are, relatively easy for us when we look at all the committees and make intentional decisions about equity related to those committees. We try to do a good job with that. Recruiting is a little bit more difficult than the committees themselves. But when recruiting, making sure that we have an intentional effort to have the equity that we need in getting the candidates to apply and be interviewed and have the chance at the position is something that we've really strove for over that period of time. Now, I'll give some data. So in the last Association of American Medical Colleges mission management tool, which takes a gaze back over the 5 previous years, the percentage of our faculty who are women is 44%, which ranks us at 73rd percentile among U.S. schools of medicine. I'll let that one sink in for just a minute. But we took a look in 2021 about where we stood with various leadership in areas. So executive leadership, including dean, associate dean, department chairs, and executive directors, 45% of those positions were held by women at SIU School of Medicine, very similar to the faculty numbers. When we added all the committee chairs to that group, 51% then of that total were women. Governance boards and committees with broad reach, 52% women. And then all other committees, 51% women, with a large number of women chairing committees. Now, it is interesting when we broke it down to types of committees. Now, not all of the committees fit within these 3 categories, but education committees, 58% were women, with 100% of the 11 women of the 11 committees being chaired by women. For clinical committees, 42% women, and for the research committees, 38% women. So it gave us an idea of, some areas that needed some work. Now, those are raw numbers. That's the diversity issue. Then we get to the inclusion and the equity issue, which is the culture of inclusion and the culture of just how we do business day to day. That culture change takes more time than changing the numbers, I think. And I'll just say, without going into all of them, we've instituted a fair number of programs. Oftentimes the good suggestions of the women themselves, and thank goodness those suggestions come. We try to incorporate as many as we can, but things like this seminar, AWIMS, all kinds of other things, we've tried to bring to a higher level than we have before, and we know that's where we aspire, is to change that culture.
Dr. Mander.
Yeah, thank you. I think at HSHS, we are on a journey. About a year and a half, 2 years ago, just prior to the COVID pandemic, we participated in a national survey with McKinsey looking at gender equity in the healthcare workforce therein. And I'd like to share some data. I think it gives an insight and probably could be easily replicated across any healthcare organization. But we did find that we nationally, we were much better than most of the other healthcare organizations. But in a profession which is predominantly female, when at the entry level you start off with 82% female, by the time you get to the senior vice president level, that drops down to 40%. So therein lies the opportunity of promotion and opportunities therein. The interesting thing we also found, not interesting thing I would say, but one thing which was also glaring was that and women of color were significantly underrepresented as we moved up the ladder, proportional to our workforce. So I think those were some of the key takeaways, that even though we are not where we are, and we have to be deliberate and intentional about this in the future. So I think all of that starts at accountability at the top. So as part of that, what we've done is we have reinvigorated our diversity and equity and inclusion programs, that is, and a committee, and it's led by our system CEO. And the intent of that is to make sure that there is accountability. And as part of that, we are reevaluating everything from our hiring practices, our policies, procedures, and also talent acquisition and other programs, to make sure that we have adequate representation across the board. Tactically, we have obviously believed that there has to be a flexibility built into the workplace where possible. Opportunities around child care, etc. Because I know women, especially during the COVID pandemic, have been disproportionately impacted therein, and more so with women of color. So we are making a deliberate and intentional effort to kind of tackle the problem, but we also intend to kind of, should I say, accelerate our training and education around implicit bias, but also around partnership and allyship therein. Because once you become aware, you can become an advocate and a partner in the journey. So I think these are some of the things we are doing at this level. Some of the other things we will probably consider along the road are like inclusion groups, resources, and others, but also looking at an opportunity down the road to partner with other similar initiatives in the community, because it's not just the organization itself, but it is a community-wide effort therein, to make sure there's adequate representation and gender equity from all aspects. So.
Thank you, Dr. Mander. Well, I'm going to get down to the nitty-gritty here and ask the panel, what do you think the top couple of issues are that we really need to start addressing institutionally and individually to start to have more equity, gender equity in the healthcare workforce? What are the issues that these committees and groups and tactics need to be aimed at improving? So what do you think, Dr. Caldwell? We can't hear you.
I would like to push back on that. I think we need to be aimed at improving is, I would kind of use the term time to completion when we speak about equity. So when I talked about pushing back, if someone was to say, what are the aspirations? I think about women being paid equal to men. I think about women being able to have the decision-making, authority, and power respected when they do occupy top leadership positions. The top issues are being stereotyped. I think Dr. Mcneese talked about just the view of incompetence, women experiencing bias and microaggressions. So the pushback is as far as how much time. I was looking at a data point earlier that said Latina women are making probably the lowest, Latina and Native American women, they're making 58 cents for white men. Collectively women, it's probably the month of April, if you put all of the women demographic groups together, but we start making equal to men. And if you were to actually pace that, it would take about 200 years. They actually have a number, 224 will be the year, 224 would be the year that Latina women specifically would start making equal to what white men make. And if we go across the panel, all of us are obviously saying gender inequity is wrong, gender pay, those gaps are wrong, the way people are treated in the healthcare who are not a part of the majority group, that those are wrong. And then if you go around and ask us for solutions, we all can be very articulate about the solution. So it's not the intelligence, so it's the will and the urgency. And so I think, what does it look like for part of our aspiration to say we will no longer tolerate this? I think about a quote from Angela Davis. She said, I'm no longer accepting the things I cannot change. I'm changing the things that I cannot accept. And if we say this is unacceptable, then what does it mean to say it's going to take years for this to change? And I think when we think about culture, I would like to define culture as the way we think, the way we speak, and the way we act. And we have all thought about equity issues. We can speak articulately about gender inequities. And then, so what does it mean that we can't act a lot more quickly? And so for me, that is something that I've shifted my mindset in, because when we think about a lot of our positions, I mean, you are a medical doctor, so ER, you have time restraints on how you can do things, right? If it's life or death. If we kind of see these things as urgent and life and death as far as not maximizing the potential of women not being treated with full dignity and humanity, if we consider those issues urgent, I think that we would be more urgent in resolving that. So one of my key things is, how can we do this and do it swiftly? Because we have the aptitude to do it, and now it's about the will and the accountability to do it as well. And one of the resources I want to put up is a book called What Works. I mean, there's a whole book. It's called Gender Equality by Design. This is not the only book by Dr. Iris Bonet. She gives very specific strategies and tools, and also shows organizations who have been able to quickly move the needle forward. So I'm offering this as a resource, but I just firmly believe that we have to kind of shift our mind that this is going to take a lot of time, because I believe it's really based on our will to change the status quo and to change the power structures that exist right now.
Thank you, Dr. Caldwell, for injecting that sense of urgency into this discussion, because I completely agree with what you're saying. Anybody else want to talk about what they think the top few issues are? I see Dr. Mcneese and Dr. Cruz. So Dr. Mcneese and then Dr. Cruz.
So I actually did not want to talk about what I thought the top 3 issues were. I'm sorry for not answering the question directly, but what I wanted to add to it is this. There was a great reluctance on my part to respond to that question because I am a man. I know that this is a panel that is made up largely of men because it's he for she. But I think as we are addressing an issue like this, it's ultra important that we hear from women what they believe are the top 3 issues, or however they want to list it. That is very important to me going forward. And so, yes, we can have something to say, but I think the women of the world should tell us what they believe we should be doing.
Dr. Cruz.
First, I'd just like to agree with everything Dr. Caldwell said. Her first 2 points were very important, but I do want to focus in on the last thing that she said, that we need to do things that will maximize the potential of women. You know, one thing I've noticed is that you can't just attack this within an organization, that outside of the workplace, there are gender inequities of all kinds that women deal with. And I don't think we can do it in the workplace without, at the least, understanding those, or better yet, you know, helping to change that culture too, at least addressing it in some way. I don't have the answer to this one, but it seems to be one that's part of the bigger solution for culture change.
Thank you. Well, I'm going to welcome Dr. Govindaya into the conversation. Good afternoon. Can you talk to us a little bit about Memorial's initiatives in the realm of gender equality and what the top issues are for you all?
Yeah, sure. And I apologize, I got pulled away for a moment. If I could just share a story of when I've personally seen this as well. And just born in the United States, my mom and dad were immigrant physicians. My mom is all of 5'0", a psychiatrist who had to deal with issues related to her profession, her gender, and quite honestly, her ethnicity, her entire career. My wife's a physician. I'm the proud father of two daughters. This is profoundly personal for me, although it's not my own personal lived experience, right? You see events that happen all the time. When I first came here as a hospitalist in 2006, I was being oriented by another hospitalist, a Caucasian female who happens to be a nurse, who then became a dentist, who then became a physician. She was about 15 to 20 years older than me, and we would walk into a room, and immediately the patient would identify me as a brown guy who's like 30 as the doctor, and her as a 50-year-old Caucasian female as the nurse. And I was like, wow, this is my first day. But it wasn't just there. It was everyone else in the hospital. It was the nurses. It was other physicians. And I asked her after, 3 days of this, does this happen all the time? And her response was, my whole life. I cannot begin to imagine what that is like, to have to walk into a room and establish your credibility each and every single time you meet someone. And that's got to have a weight and a pain that I cannot comprehend. In terms of what Memorial is doing, I think our journey is very similar to the journey that Dr. Cruz and Dr. Mander have shared. We have a leader over equity, diversity, and inclusion who, in hindsight, I probably should have asked if they could join this, Valeria Cueto. just to be a fly on the wall. In the last 6 months, we've embarked on a assessment of where we stand as an organization as well, with a assessment by an external organization, Korn Ferry. We're supposed to get that report back actually sometime in the next month or two. I think COVID slowed it down a little bit. So I cannot give you hard statistics, or recent statistics, but what we see is exactly what all of you see. We now have medical school classes with greater than 50% women, but when you get to the leadership roles in our organizations, you don't see the same representation. When you look at physicians, and I look at the residency complement across the School of Medicine, who I believe has done a remarkable job of trying to create a tolerant environment for all, I do not see a balance in procedural specialties of men and women outside of OB. And so, this will be our life's work. And recognizing it, I think, is an important part of how individuals like me, who might have some privilege that I don't even understand, can begin to help lend a hand and be an ally.
I'm gonna deviate from my moderator duty for just a second to make a comment, because I really appreciate all these points that are getting made. Dr. Caldwell and then you, Dr. Govindaya, have alluded to the fact that although medical school classes are now 50% or more women, thanks to Title IX, thanks to federal legislation that mandates that, not because of an incredible change in our culture. We see all these wonderful, accomplished young women applying to and getting into medical school. However, when we look downstream and look at available practitioners in a community, people in leadership roles, or just women physicians in the workforce, we see that 50% women in the workforce is falling, 50% women in medical schools falling off. What I would argue is we did change a policy about who gets admitted to medical school. Wonderful, it worked. We have a lot more policies to change so that women stay in the physician workforce, rise up in the physician workforce, et cetera, et cetera. And to me, one of the screaming issues is childcare and elder care, because women in our society definitely bear that burden in their families. And physicians, they want to be good at everything they do. So of course they want to be super moms and super spouses as well as super doctors. And that is too much of a burden. You can't do it. And so what institutions do to support women in those societal roles, I think, is a huge part of the story of keeping women in the physician workforce. And of course, changing policy and allocating resource is right now the job of a predominantly male group of people who are making these decisions. So that kind of leads me into my next question. In what ways is it important for men to support women as allies, and how can we get more men to support women in concrete ways as we go through these endeavors? What are your thoughts on that?
So I can say a few words. I think we all need to be partners and allies on this journey. And I think it all starts with awareness and education. And that is why when we look at our own initiatives within HSHS, we are working towards increased awareness and education and giving them the resources and the tool to understand where we are and where the opportunities may lie. Because, it's study after study has shown that when you have supportive colleagues and co-workers who call out things as they are, mentor each other and support each other, and don't tolerate any form of aggression, microaggressions, etc. You have a more, should I say, productive and satisfied workforce, and it helps with retention too. So to me, it all starts at increasing awareness, and I anticipate all the males in the room. We've all gone through our own journeys of becoming more aware and astute over time about the issues, about gender issues, because they don't impact us directly, but then we see that in the families, our sisters, and and others experiencing those. So I think that is where it starts, and then as an organization, you need to support them, and also within the organization create accountability therein, that DEI work and gender equity work, it is part of the expectation of our performance expectations therein. Just some thoughts on that.
Absolutely, Dr. Mander. I agree.
Can I jump in, Kristen? As you asked about like some of the challenges, and I was thinking about how men can report, I was looking at one study and it just talked again about how women report the stereotypes and preconceptions about women's roles and abilities are the #1 barrier to them being advanced in their field, closely followed by a lack of role models, a lack of management experiences because they don't have those opportunities. And then as you talked about, Ms. Todd, commitment to family and personal responsibilities and lack of mentoring. And so I said that to say that even like if I could just kind of think about my onboarding here, and I'm going to specifically talk about Dr. Mahoney, one of the things that was very attractive to me even coming to SIU is during the interview process, he mentioned, he said, I have mentored individuals who have a desire to become a college president. During the interview, he said, if that's something you aspire to do, I would be pleased to help you do that. And so I had never actually had someone say, I mean, I didn't have the job, I hadn't been offered the position, but the fact that he actually said, if you get this role, if you're offered this position, if that's something you aspire to be. And so I think about, again, lack of role models and lack of mentoring. And so just the fact that he put that out there, like I've already thought about in the future, what would it look like, when, in the near future, when I decide that I might want to do that, rather be at SIU or another location, knowing that he is going to invest in me and help cultivate an environment for me to grow into that leadership role. So I said being proactive. I think that was very encouraging to me. It makes me not just come to SIU, but want to stay because he's already demonstrated that type of commitment, and also that I have a role model. So I just wanted to kind of speak from personal experience as far as what, particularly our current leader has done to encourage me and to show allyship. And I think the last thing I want to say is oftentimes when we use terminology like allies and gender equity, or when we speak about race, I think it's important to know that we all aspire to have leaders who promote fairness, justice, who have a desire to do what is right. I mean, and those are just the definitions of equity, doing what's right, being fair, being just. So oftentimes I see individuals as allies to that more so than the individual. Like, what does it mean to just advocate for righteousness or for fairness or justice? I mean, ultimately, that's what you're really an ally to, not so much an individual or a principle, but it's the overall overarching principle of justice, of fairness, that we all should aspire to be leaders, because we know that that's going to create more balance. That's going to create more peace, more harmony, and again, more people fulfilling their potential. So that's also how I view equity. It should be just because that's part of having integrity and being a good leader.
Yeah, about aligning with your personal values and upholding that systemically as well as personally. Yeah, I think that's a wonderful point. Dr. Cruz.
What Dr. Caldwell said again, Sheila, you're really you're hitting everything right on the head here. It's really good. So what I thought of when you said that was, okay, well, now how did we know that the leader that came in would have those characteristics? Is that always apparent in an interview process? Sometimes if they come from within, it's pretty easy to know that. But if you're interviewing them from the outside, it may be difficult. I know some organizations for the leadership levels actually do a battery of psychological testing. Will those things come through in that type of testing? I don't know the answer to that. And then it's recruiting at all other levels. And the question gets to be, how do you recruit men to be candidates for these positions, who will further all of these values and principles and the things that change culture. I don't think I've got an answer for that, as a matter of fact, but it is, again, this is stimulating a lot of thought for me, which is very good. So I appreciate it.
If I could make a comment too.
Govindaya, yes.
Dr. Caldwell, you sharing that story is so powerful because I think in some ways, and I don't want to ascribe a thought to you, but I think in some ways we don't always see the potential in ourselves. We don't see a path forward for ourselves. And so when Chancellor Mahoney said, do you want to do this? It may have never occurred to you to do that. And now you're like, oh, someone thinks I might be able to do that. I have recently, in a very small way, had a similar experience. My role at Memorial got split into two roles, basically, and had to recruit for the role at the hospital. And the person I ended up offering the job to is someone I talked to a year ago and said, you could do my job one day. And I don't think that would have happened if that conversation hadn't occurred. I will also say that I talked to one female interviewed 4 people, all men. I talked to one female candidate and had 2 other people approach them and ask them if they would apply, and I couldn't get them to apply. But I think sometimes what I think I hear, and I think one of the obligations of us as men in roles of influence is, how do we identify people and tap them on the shoulder and say, I think you could do this, or you should think about doing this? Because I'm not sure that individuals are going to self-present. And the other thing I would say about men versus women, and I think there's actual kind of some psychological or statistical basis to this, is that men are more likely to apply for, like if you were to put out a position with 6 requirements for it, men are more likely to apply if they meet most of the requirements, whereas women will not apply unless they meet all of the requirements. And so the thing is, like, you're like, women hold themselves back. I have no idea why. My understanding is that I've heard this quoted in the literature, and then you're like, how do you encourage them to step forward?
I love that point, Dr. Govindaya. You know, when we have these conversations, I hear from so many women about the fact that they wouldn't have the position they had if a mentor, and it's often a male mentor, hadn't said, you apply for this. Come on, you're the person that I think can do this. So that kind of personal, individual mentoring and encouragement, I think, and sort of endorsement, private endorsement is incredibly powerful on an individual level. I'm really glad you brought that up. So I have a final question that I'd love to hear an answer to, which is...
Hey, Christine, Gurpreet has his yellow hand raised.
Oh, Gurpreet, go ahead. Yeah.
I just sort of Raj's point kind of brought out something from my memory. I read somewhere that men would apply for a position even if they had 60% competency for that particular job, and that is a fact. Now, I just want to share an anecdote which kind of hits home to all of us. When we recently put out our call for nominations for MEC, and our committee decided that they would send it out at large. I don't recall one female, female physician actually stepping forward and self-nominating, whereas a fair number of males did. However, the committee was very deliberate when we went in to make a decision to make sure we have the representation. And I think it's just an interesting observation. I thought that would pique your interest. So.
Yeah. So here's my final question. What is a characteristic that our culture usually attributes to women that you would like to see more of in healthcare?
I can go again.
Dr. Mander.
Yeah, I think some of the traditional attributes, to women around caring and compassion and empathy obviously apply to healthcare, and are just wonderful attributes. But I think when it comes to leadership in particular, I feel that there's certain traits female leaders have more in common than men, and that is around empathy, listening, and teamwork. And also it's been shown time and time again in studies that women leaders spend more time in engaging their colleagues, in listening to them and understanding their pain points. And that in the current environment we are in is an extremely valuable trait for both for recruitment and for the retention of our colleagues. So just some thoughts on that. So
That's a great one. Okay, Dr. Govindaya. Oh, I'm seeing lots of hands.
Yeah, I would echo everything that Gurpreet just said, and I will also say, as the father of two girls, and Dr. Mander has two girls as well, I'm always struck by the fact that I don't think men and women are raised to boys and girls are raised with the same set of expectations. Women have a unfair set of expectations, which are, hey, if you're that assertive, you don't appear to have that compassion or that empathy that that is ascribed to women. And so I think the balance is, how do you become an effective, assertive leader while still maintaining all those capabilities? And I think actually women do a much better job of that than men.
Yeah.
Men tend to bulldoze a little bit more than women, and I think there's a reason why, but we cannot remove that assertiveness from our young women in the process, and hold them to a different standard than men, and then expect them to lead um, on a playing field that's defined by men.
That is the conundrum precisely, Dr. Govindaya. Absolutely. You are right. So Dr. Caldwell.
Thank you, Dr. Todd, and my apologies for the error earlier. I do want to say it publicly because one of the mistakes that actually often get made in these type of panels is we refer to men as doctor and women as miss, and clearly you're Dr. Todd, and I made that error, so I just wanted to correct myself with that. But the three things I wanted to mention was collaboration, kindness, and I would say listening. And I think specifically, I know listening obviously works well and needs to be at the forefront in medicine, but I also think about just listening to women when we actually share our stories and we talk about our lived experiences. Oftentimes we're discounted. It's like, are you sure that's really happened? Are you sure your perceptions are accurate? So oftentimes we're undermined, we're discounted, and it actually just creates further injury and harm when you are basically being gaslighted after you share your experiences and make it feel like what you're perceiving is not real. And then the thing that's even more startling about that, I was listening to one of the stories. And so, what would it look like for a male doctor to be like, well, oh, actually, she is a woman doctor? Then she's more likely to be believed than her even saying it herself. So, what does it look like that men's affirmation are even greater than what we say? We're not even credible in our own lived experiences and our own stories. And so, I think that that's something that definitely needs to change. We need to be listened to, and we need to be believed the first time, because it's not all in our head. It's things that are happening to us, and it's actually very well documented and supported by data.
True for women physicians, but also women patients. Mm-hmm. Dr. Mcneese.
Well, it is said that women are more communicative than men. Communicative in the sense that they are ready to talk and easy to talk to, maybe imparting information. And I think it would be helpful to healthcare, both on the clinical side and on the administrative side, if we had people who were more communicative and willing to give out more information. A lot of times when when I'm working in those settings, it seems like people aren't saying what they really want to say, that there's something being held back, that there's a secrecy or a lack of transparency as we go forward. And if women truly are more communicative, I'd love to see that characteristic be carried forward more in healthcare.
Yeah. Dr. Cruz.
So all of the things I've heard sound really good. You know, it made me think again of the radical candor. And, you know, right early in the book, it says, we're going to strive for open communication, praise, and constructive criticism. You know, that axis of caring personally is described that way. And, you know, I couldn't think of anything better to say than that. But I do have to reflect a little bit on being the father of only daughters, right? Food group. I'm 3 daughters, and 2 of them have positions in higher education now. And you know, it is interesting hearing stories. They've been at various places, and I hear this from others as well. But you know, as you're working there, and you have a superior who's a woman who's actually come up through the old hierarchy and doesn't exhibit that, is more like the old school. I think a lot of people have experienced that. That's a hard one to deal with. And I don't know if I've got the answer to that one, but just as we were talking, and I was thinking about what Raj and Gurpreet said, it's like, yeah, you know, that's one that, you know, I don't face that at SIU, but it probably is one in organizations that occurs.
Yeah, absolutely. I think, you know, things about our culture have changed. And I think way back when women were getting admitted more to medical schools after Title IX, the deal was you had to give up some of your female identity to be like a man and do it that way. And that was the price you paid for being allowed in the club. And that, thankfully, is starting to change. And I love to hear about all these attributes that we recognize we don't want women in healthcare to give up in order to do it like a man. We need to do healthcare differently, and more women are part of that. And the empathy and the caring and communication and collaboration, totally agree. But we have further to go. But that's one of those things where I can look at and realize that my experience, for instance, is very different from the experience of a woman who went through this 20 years ago. Dr. Prakash.
Dr. Todd, I want to thank you for moderating a really phenomenal discussion today, and many thanks to every one of our panelists for a really thought-provoking conversation. I do want to draw your attention to the chat. Dr. Robert Robinson put in a link to a Google Doc to join our He for She working group. This is open to everybody who has an interest in allyship. So please be sure to sign up for that. I do have a comment and a question for our panelists. So my comment is, you know, we talk about, are we needing to fix the women, or do we need to fix the system? And it absolutely is the system. Our focus should not be fixing the women. The women are not broken. So when I think of anecdotes, including myself and from a lot of my women colleagues who have been in leadership positions, as we have heard from our panelists, most of them were tapped. They did not volunteer to sign up for those positions or apply, they were tapped. And an overwhelming majority, it wasn't because they lacked self-esteem or self-confidence. It was because they knew they were up against a system that was working against them. And so that needs to be the focus of change. It really needs to be fixing the system and not the women. And my second point and question has to do with metrics of success. And when we look at success, a lot depends on our anchor. So if we anchor 100 to 150 years ago, sure, we've made tremendous progress, right? But if you anchor 100 to 150 years from now, if that's our anchor, we have a long way to go. So, you know, my question for our panelists is, what does success look like for you? Hopefully it won't be 100 to 150 years from now, but in our near future, what does a just and inclusive environment look like?
That's a great question, Dr. Prakash. Thank you.
I'd like to start off by saying that oftentimes we talk about what we want. I like to think about a commission and omission. So to me, just is that women can be well represented not only in healthcare, but through all levels of society where they desire to be, that they can show up as their full, authentic selves, meaning that what we want to omit is the constant need to code switch, to assimilate, that women can have dignified experiences. Again, that we create structures where they can be healthcare providers, that they can also be good moms and good spouses, because we play multiple roles. And if we want future generations that also can do well, we have to support women who actually are at the forefront of being caregivers and providers. So those are the things that I would like to see. We talked about daughters. I have 2 daughters, and part of the reason why I do this work is that I want their burdens to not be the same as my burdens. And I have an imagination that we are equipped to make that happen, that they can be less burdened and they can live in a more vibrant, equitable, and just society. And that will be thanks to all of our efforts in a very swift manner, I would like to add, and we can do it swiftly.
Vidya?
Go ahead,
Yeah,
Dr. Cruz.
I'd just say success would probably be that it wouldn't even cross our minds that we would have to have a discussion like this.
Yeah, I was just going to chime in. I might have a definition of success, but to go back to Dr. Mcneese's points earlier, I'm not sure I, as a guy, should be defining what success is. I would like to be informed by what, my female colleagues or my Black colleagues or my, Hispanic colleagues, what they think success would look like. But I'm not sure I should define it.
Well, I live in hope that someday we do have a system where nobody feels like they don't belong. Truly inclusive. That would really be wonderful.
Dr. Todd, thank you so much again. Many thanks to each one of our panelists, Dr. Caldwell, Dr. Govindaya, Dr. Cruz, Dr. Mander, Dr. Mcneese. You have given us a lot to think about, and I remain inspired by your collective leadership. With each of you and with this tremendous group that has joined us today, I remain hopeful. So much, much gratitude. Thank you all for joining us. Many thanks again, Dr. Todd.
Thank you. Bye-bye.
Thank you.